Ruth Carnell is at the heart of NHS policy making in London. But what bearing does policy have on the day-to-day work of a junior doctor? She talks to Darzi fellow Carlo Prina.
In the other podcasts and in other material, we talked a little bit about some of the principles that underpin the NHS. And I was wondering, are there similar principles that are used when you're coming up with a new policy?
If you look at the needs of London as a place, the first thing that's obvious is the massive diversity that exists on every possible front in this city in a way that it doesn't in other parts of the country. Performance of hospital services widely variable, financial performance widely variable. Some of the world's most famous specialist teaching hospitals, Great Ormond Street, other end of the spectrum, some of the poorest standards of primary care in the country, and everything in between. So our approach to that has been to try to develop a set of policies for London which are specific to both the health needs of our population and the role that London has for the country as a whole that meets both the needs at both ends of the spectrum. So the key themes of that have been localised services wherever possible. So try and develop models of care which dramatically improve the access of the population to primary and community services much closer to their home. Stop people having to rely excessively on hospital services. So most people, or a significant proportion of the population, rely on A&E departments to provide their primary care. That's an inappropriate model of service. A&E departments should be for people who arrive in a blue light ambulance who have a serious urgent care need, not people who can't get access to primary care. So one big theme of ours has been to try to develop polysystems, we've called them, across London, but essentially finding ways to give the population access to primary care during extended hours of the day and night, wider range of community services, outpatients, diagnostics, other services that can more effectively and more appropriately be provided closer to home.
If we take the example of a framework for action,
Yep.
so the NHS London plan, if we try and think about some of the tensions that exist, you talked a bit about some of these principles, and these are big principles. Even within quality, you have the principle of effectiveness versus safety versus efficiency. There's always going to be a trade-off potentially between those things. When policy is being devised at the top level, how do you try and manage those trade-offs between really important things to come to something that's got some universal value to it?
Okay, so if we take an example to illustrate it, we take stroke care. At the moment, although things are changing almost as we speak, but at the moment, if you have a stroke in London, you will get taken to your local hospital, more than likely. If that local hospital happens to be St George's, then there's a very, very good chance that you'll get thrombolysis within 3 hours of the onset of the symptoms that you've had. Very good chance. But if you get taken to a smaller hospital out on the periphery of London, there's a very, very small chance that that's going to happen. In fact, in some hospitals in London, you can be admitted with a stroke and not see a neurologist for 30 days after you've been admitted. That can still happen at the moment in London. So that's very variable quality of care as a minimum. It's very inefficient. Lots of patients staying in hospital for very long periods of time, suffering very poor outcomes. Our approach to that was to get a group of clinicians together to say, what's the international best practice on stroke care? And to research that really thoroughly, out of which came, and it wasn't as easy a process as I'm now about to describe, but out of which came, what you need is a limited number of hyperacute stroke centres where you can guarantee 365 days a year, 24/7, that patients can get access to the right sort of CT scan, the right diagnosis, the right treatment, thrombolysis if that's appropriate, neurosurgery if that's what's appropriate, where they stay for a minimum amount of time, after which they're discharged to a properly equipped stroke unit, and after that to properly supported primary care, rehabilitation, social care, a proper care pathway for patients. So we had a huge amount of debate about how many centres should we have in London? How big do they need to be to get the expertise that you need? Where should they be located in order that ambulance journeys are appropriate? What sort of network of stroke units should we have around that? What's an appropriate provision of and standards for rehabilitation? That part of it was not straightforward, but relatively scientific. So a study of what's best practice, a debate and an evaluation of how might that fit in London, and then a description of that as a care pathway and as a judgment about whether we should have 4 hyperacute stroke units, 8, 10, 12, and we settled in the end on 8. The politics of it, which kicked in after having come to that conclusion, were difficult, because what you're saying then to people is, if you have a stroke, you're not going to be taken to your local hospital, you're going to be taken to somewhere that's quite a long way away. People find it really, really hard to accept that their local A&E department does not provide everything that they need. Now, as professionals, as doctors, you would know that that's the case. You know full well that there's no such thing as a standard A&E department and a standard hospital offering behind it. So persuading the population and their representatives, their local authority and their MPs, that this is a safer, more effective form of care that can save hundreds of lives in London a year, we took actually quite a lot of opposition on board, even to deliver something that most clinicians would think was very, very, very well evidenced. So the stroke care is one that's well known, it's well understood. People, clinicians would certainly easily accept that the model of care is the right one and that the changes are legitimate and appropriate and they'll improve quality. But getting patients, the public and their representatives to accept and understand that is very difficult.
Talking to junior doctors, in fact many senior doctors, there can be, unfortunately, some cynicism when it comes to policy, both from the point of view of why does it affect me on the shop floor, particularly for junior doctors, that can be very difficult to understand. And also for more senior colleagues, that they become perhaps slightly cynical about having been through the cycle of change many times. What would your advice be to doctors about why they need to still know about policy as it's changing?
Well, ultimately it's a question of you want to be done to or whether you want to be doing the doing. So for me, an absolutely critical part of delivering any sort of major change programme in the NHS is to have appropriate clinical leadership, both deciding what needs to be done and leading the doing of it. And that's absolutely what we've tried to do with Healthcare for London. So the changes that I've just described around stroke care, same around trauma care, cardiac care, cancer care, vascular surgery, all of those things that we're working on at the moment, all of them clinically led. The polysystem programme led by GPs, the mental health strategy that we're working on at the moment led by a psychiatrist working with a team of clinicians. So it would be absolutely my ambition to put clinicians at the heart of leading any of these change programmes. And I recognise the cynicism that you describe. There are groups of clinicians who have got so cynical about everything that, frankly, no matter how much I might want to do it, they're not now going to change. And I have to accept that. But for the future, we have to build leadership capability in people at an earlier stage in their career. And they have to be able and willing to combine that with a clinical career. And we've not offered enough options for people to combine their clinical work with a growing leadership responsibility, such that perhaps towards a later part of their career they feel okay about taking on a bigger leadership role. What we've tended to do is to say, you do nothing but doctoring, and then there comes a point where suddenly we expect you to be a clinical director. Or even worse, suddenly we expect you to be a chief executive. So somehow there has to be something that allows much more of a marriage of two different approaches throughout a career, ultimately maybe leading to some taking on full-time leadership responsibilities, but not as a necessity.